snake bite care, fast, focus and standardize. Outline. During next 15 minutes, I would like to talk to you on the burden of snake bite envenoming in Sri Lanka, why we need snake bite care, fast, focus and standardize, and mostly I discuss key information on medically important snake, clinical evaluation, management and prevention of snake bite envenoming. The burden of snake bite envenoming in Sri Lanka. Snake bite envenoming is a neglected tropical disease in Asia, Africa and South America announced by WHO since 2017. Sri Lankan hospital data showed 40,000 of snake bite cases were admitted to our hospitals every year. So incidence was 180 per 100,000 population, and we have nearly 100 deaths of snake bite envenoming every year. Hump-nose pit viper is the commonest cause, and most fatalities are due to rhesus viper envenoming. Why we need snake bite care, fast, focus and standardize. Snake bite envenoming is a potentially fatal medical emergency, also timely needed, and identification of snake species is clinically challenging, we all know. And antivenom saves countless lives, that's very useful, but we know it is associated with severe reactions and limited potency. Also, the possibility of antivenom reactions generates fear among many healthcare professionals who are working in especially periphery. They are a little reluctant to give sometimes antivenom for patients who need antivenom. How can we achieve this? So we need adequate knowledge of snake bite envenoming, especially among healthcare workers. Everybody should know snake identification, especially medically important snakes, and also should educate community on health snake bite envenoming. So patients should admitted to the hospital, hospitalization, and then administration of effective antivenom is very, very useful, and we should provide supportive care. Harmful traditional beliefs and practices should be avoided. So we need region-specific, evidence-based guidelines and other information, education and communication materials for snake bite care and management. So what are the medically important snakes in Sri Lanka? You all know historical classification is non-venomous, mild, moderate or highly venomous snakes. Now classification is different according to the WHO classification. We classify snake as medically important snakes or medically not important or less important snake, depending on their envenoming features. If patient has significant morbidity and mortality, we consider the snake is medically important snake according to the WHO criteria. So we have in our country 10 species: cobra, common krait, Sri Lankan krait, rhesus viper, 3 species of hump-nose vipers, green pit viper, sour scale viper, and Sri Lankan keelback or blossom krait. I quickly go through this slide because I have limited time. So you know this morphological features I am not going to discuss: cobra, common krait, Ceylon krait, sour scale viper, rhesus viper, and 3 species of hump-nose vipers, green pit viper, and this is Sri Lankan blossom krait or keelback. So let me talk a few words about what is Sri Lankan blossom krait or Sri Lankan keelback. There is a case report published in Toxicon. The patient was a 33-year-old healthy biologist who was bitten by a snake, and he developed severe headache, photophobia, syncope, hematemesis, bleeding from the puncture site. Also noted coagulopathy by elevated INR and positive D-dimer test. He was treated with FFP and patient recovered. This is the offending snake, and the snake is Sri Lankan blossom crate or Sri Lankan keelback. And you can see these characteristic morphological features, and it was published in Toxicon as first reported case of systemic envenoming by the Sri Lankan keelback. After that, expert committee decided to include this snake also as a medically important snake in Sri Lanka. First states. So first we should move patient from the safety to the safety and reassure the patient and remove constricting clothing, rings, etc. And immobilization of the affected limb is very important. Then transfer patient to the hospitals where AVS available. Avoid the many harmful and time-wasting traditional first aid treatments. You can use paracetamol for the pain, and tight tourniquet or arterial tourniquet should never be used. Initial assessment of snake bite victims. All patients should be admitted to the hospital for assessment, observation, and treatment if necessary. Then we stabilize the patient by using ABCD approach. So look for the evidence of envenoming using clinical, epidemiological, and circumstantial evidence. Then assess coagulopathy by performing 20 WBCT. This slide shows clinical features of different species of snake bite envenoming. And you know, Russell's viper bite envenoming causes local effects, coagulopathy, and neurotoxicity. Cobra, mostly local effects and neurotoxicity. Crates, neurotoxicity. Saw-scale viper, hump-nose viper, green pit viper, mostly local effects and coagulopathy. And Sri Lankan keelback cause coagulopathy and bleeding manifestations. Syndromic approach is very important when you have a patient with snake bite, because sometimes patients come to the hospital, they didn't bring offending snake or specimen, or they don't have photographs, so it is difficult to identify. So we use syndromic approach for the diagnosis. I'm not going to discuss more details. You know what are the characteristic clinical features of cobra bite, Russell's viper, crate bite, saw scale, hump nose, as well as green pit viper bite. 20 minutes whole blood clotting test, 20 WBCT is very important. 20 WBCT has low sensitivity and should not override clinical assessment-based decisions. It is recommended that to do PTINR routinely together with the 20 WBCT. How can you do 20 WBCT? It's a very simple test. Collect 1 to 2 milliliter of blood into glass test tube and leave it unshaked or undisturbed for 20 minutes. At the end of the 20 minutes, tilt the test tube and observe whether there is a clot. If clot is there, that there is no, this clot is there and the test is negative. If blood flows and clot is not there, test is positive. So everybody should know how to do this simple 20 WBCT in the ward. So let me to discuss management algorithm of snake bite envenoming. So if you have a patient with a history of snake bite envenoming or suspected case, then you have to admit patients to the hospital and stabilize the patient. Then assess for the signs of envenoming and continuously monitor vitals. And also look for evidence of identification of the snake. You can use if specimens available, or sometimes patients bring photos, videos, then sometimes patient describe about the snake, or you can use epidemiological criteria for the diagnosis of the snake or identification of the snake. So very important. Then assess for the envenoming. So you can see whether patient is having symptoms or signs of local envenoming like pain, bruising, and other local signs. Then systemic envenoming, signs like coagulopathy, prolonged 20 WBCT, neurotoxicity, nephrotoxicity, myotoxicity, and especially I highlighted here early non-specific features of systemic envenoming is very important, like vomiting, malaise, abdominal pain, weakness, drowsiness, prostration. Those are early signs of systemic envenoming, because if you noted early signs of envenoming, so we have to think about antivenom therapy. Also, we should update tetanus status, also avoid NSAIDs, intramuscular injections, also concurrent administration of sera, narcotics, and other respiratory depression. Your patient may be envenom, may not be envenom, or may envenom. So if your patient is envenom, so look for local, maybe having local envenoming signs only. Or sometimes that patient develops systemic envenoming signs. So keep in mind, if your patient is having systemic envenoming signs or local envenoming only following cobra bite, need antivenom therapy. So systemic envenoming all patients after snake bite, and local envenoming after cobra bite need antivenom therapy. Then not envenom, or patient may having local envenoming only except cobra, observe for next 24 hours for the signs of systemic envenoming. Patient may develop systemic envenoming signs and symptoms, then go ahead and start antivenom therapy. And if no systemic envenoming signs or symptoms, you may discharge the patient. Then antivenom administration. Antivenom therapy should be commenced as soon as possible following the systemic envenoming. Antivenom should not be administered for local envenoming except cobra bite. It is never too late to give antivenom provided the indications are present. You all know Indian antivenom is prepared using venom of 4 highly venomous snakes. Antivenom administration, you can use 100 to 200 milliliter or 10 to 20 ampules of Indian ABS in 400 milliliters of normal saline, infused over 1 hour. The dose of antivenom depends on the severity of the envenoming. In cobra and crate bite, usually we need 1 antivenom dose or 10 ampules is sufficient. In the case of rhesus viper bite, envenoming, you may need 20 to 30 ampules, and you may repeat it after 6 hours if coagulopathy persists. The endpoint of antivenom therapy is reversal of coagulopathy as determined by serial performance of 20 WBCT. Do not continue antivenom administration for persistent neurotoxicity. Antivenom reactions is very common. The very important low dose adrenaline 0.25 of 1 in 10,000 you can give just before commencement of antivenom therapy. Very important to prevent the or reduce the antivenom reaction. However, early detection and vigorous treatment is very useful, and pre-medication with antihistamine and hydrocortisone is not advocated. Very important, right? And treatment, for the anaphylaxis, non-pharmacological and ABCD approach, and stop antivenom infusion, and pharmacological treatment adrenaline, and you can use bronchodilators, nebulization, IV Piriton, and intravenous hydrocortisone. Supportive therapy, tetanus toxoid, fluid, antibiotics, surgical care, and ICU care. And we have to prevent, how can you prevent snake bite? Avoid snake entering into the houses, use light or wear shoes, clear heaps, rubbish, keep grass short cuts, and listen to the domestic animal. Let me to summarize my presentation. Snake bite envenoming causes substantial morbidity and mortality, and it is a neglected tropical disease in Sri Lanka. Snake identification is important for the evaluation and management of envenoming. Antivenom therapy should be commenced as soon as possible following the detection of systemic envenoming. Antivenom should not be administered for local envenoming except cobra bite, and raising community awareness about prevention of snake bite is the most effective strategy for reducing snake bite envenoming and mortality. These are my references. Thank you very much.